So we have a 64-year-old woman with hypertension, type 2 diabetes, who presents to the ED with left lower extremity swelling, warmth, and pain for the past 4 days. Her temperature is 100.8. She has asymmetric swelling of the left calf and tender erythema extending from the toe to the knee. Her labs show a white count of 15,000. So what's your next step? And I want you to just think about this and commit to an answer in your mind. So A, is it order a duplex ultrasound of the left leg? B, order a duplex ultrasound of both legs. C, admit for IV antibiotics. Or D, admit for IV antibiotics and order a duplex ultrasound of the left leg. I'm going to give you about 10 seconds to commit to an answer. Okay, so I'm going to tell you the answer here was to admit for IV antibiotics and not do an ultrasound. So now let's talk about why. So the clinical features of DVT and cellulitis actually very much overlap, right? So you can have fever in both. You might have erythema. You might have leukocytosis. And you might have asymmetric edema. So with all of these things overlapping, how do you tell the difference between them? So you might be wondering, well, if there's no way to tell the difference clinically speaking, why not just do an ultrasound in everybody who comes in with cellulitis? So you're weighing the cost in your mind of the misdiagnosis of a DVT or PE, which could be pretty bad, versus the cost of unnecessary testing and finding things you don't want to find. So they've actually studied this, and in up to 73% of patients who come to the ER with lower leg, any lower extremity cellulitis, 73% of them get a routine ultrasound in the ED. How many of those actually have a concurrent DVT? About 3%. In some studies, the incidence is even lower. And this is all DVTs, not just proximal DVTs, which are the ones that we most care about from a clinical standpoint. On the flip side, the cost of every ultrasound is about $1,300, plus extra fees if your radiologist bills for more. So you might be wondering, what am I supposed to use now? If you turn to the Wells score, does this help us? So here's a reminder, the Wells score includes all of these clinical features here, and a less than 1 gives you a low risk. Anything 1 to 2 points gives you intermediate, and 3 or more is high risk. But the problem with the Wells score is that all of these features here in blue are common in both DVT and ultrasound. So in a lot of studies, it's been shown that the Wells score overestimates your risk of a DVT when you have a patient with concurrent cellulitis. So then what about a D-dimer? So D-dimer, as you might imagine, is elevated the majority of the time in patients who have cellulitis as well, and so not clinically useful. So what should we do instead? Instead, you should take a thorough cellulitis history. So if your history is thoroughly consistent with cellulitis, like they had skin breakdown, recent trauma, maceration of the skin, that's more likely your diagnosis. Then you should just treat for cellulitis and watch for improvement. If they don't improve, then you should look a little deeper for another diagnosis. And then you should assess their individual VTE risk. So what does that actually look like? So this is from the Things We Do for No Reason journal article series in the Journal of Hospital Medicine. They say that these are the actual risk factors for VTE. So recent surgery, immobility, personal or family history of venous thromboembolism, and then all these medical conditions here that could contribute to thrombophilia. So a summary for you guys, and remember bit.ly/IamFastFacts will take you to all of these. Just remember that Wells score overestimates the risk of DVT and cellulitis. Do not order a routine duplex ultrasound for lower extremity cellulitis because there's low diagnostic yield and it's a very high cost test. So instead, you should take a thorough cellulitis history, start empiric treatment for cellulitis and watch for improvement, and then consider the patient-specific risk factors for VTE, which are all listed here. And that's it.